By the end of this video, you will be able to interpret a full blood count result and spot common abnormalities. This simple blood test is incredibly powerful. Understanding it is a fundamental clinical skill, helping doctors make swift and accurate decisions. The full blood count, often called the FBC, is one of the most frequently requested blood tests within the NHS. It gives us a snapshot of the cells circulating in your blood, providing essential clues about your overall health. Spotting infections, diagnosing anemia, the FBC is a cornerstone of medical investigation. So, what exactly is an FBC? Put simply, it counts and examines the different types of cells in your blood. Red cells which carry oxygen, white cells which fight infection, and platelets which help the blood to clot. When their numbers are too high or too low, or if they look unusual, it can signal that something is not quite right in the body. It truly is a universal test, providing a baseline for health and a guide for treatment across all fields of medicine. In modern laboratories, the full blood count is performed by an automated haematology analyzer. These machines are fast and precise, capable of processing hundreds of samples every hour. First principle, electrical impedance. Cells pass through a tiny aperture, each one creating a pulse. The number of pulses equals count. The pulse size relates to cell size. Second principle, light scatter. A laser beam hits each cell. Forward and side scatter patterns reflect size, shape, and internal complexity. For example, granular neutrophils differ from smoother lymphocytes, allowing classification. Analyzers also flag results outside range or unusual patterns, pausing samples for human review when needed. This safety feature helps ensure serious abnormalities like leukemia are not missed. The machine does the high-volume work, and it knows when to ask an expert for help. Together, impedance and scatter produce reliable counts, differentials, and flags at scale. On an FBC report, you will see the patient's results next to a reference range. This range reflects typical values in about 95% of healthy adults. It is a guide, not a rigid boundary. A slight outlier may be normal for an individual, while an in-range result might be concerning if it has changed significantly. Doctors interpret numbers in context, symptoms, medical history, and previous results. UK reference ranges vary slightly between labs, but typical values are consistent. Haemoglobin, male 130-180 GL, female 115-165 GL. White cells 411-109L, platelets 150-400-109L. Children's ranges differ, and adult hemoglobin varies with hormones and menstruation. A WBC of 15.0x109 used to L suggests infection or inflammation. Platelets of 80-109L increase bleeding risk. Biomedical scientists validate results before release, ensuring accurate numbers. They check flags and scatter plots, and when indicated, prepare and examine a blood film. Hemoglobin is the protein inside red blood cells that carries oxygen from your lungs to the rest of your body. Measuring hemoglobin level is a key part of the FBC and the primary way we diagnose anemia. When hemoglobin is low, tissues do not get enough oxygen. Symptoms include fatigue, shortness of breath on exertion, dizziness, pale skin, and a rapid heartbeat. Low iron deficiency, vitamin B12, or folate deficiency, and anemia of chronic disease. Blood loss may be acute or slow and chronic. Low hemoglobin with a low MCV strongly suggests iron deficiency anemia. A high hemoglobin level, polycythemia, makes blood thicker and harder to flow. High dehydration, smoking, living at high altitude, and less commonly polycythemia vera. Symptoms include headaches, dizziness, a reddish complexion, and itching after a warm bath. The main risk of very high hemoglobin is increased clotting, which can lead to a stroke or a heart attack. White blood cells are the soldiers of your immune system. The FBC provides a total white blood cell count. When the body fights bacteria or viruses, the bone marrow often raises production. A high white blood cell count is called leukocytosis. Infection is the most common cause. inflammation, physiological stress, and certain medications like steroids can also increase the count. A very high persistent count, especially with abnormal-looking cells, can suggest leukemia and must be investigated. A low white blood cell count, leukopenia, increases vulnerability to infection. Causes include viral infections, bone marrow problems, chemotherapy or radiotherapy, and severe sepsis, which can consume white cells. Differential counts add clues. Neutrophils often rise in bacterial infection. Lymphocytes often rise in viral infection. This distinction helps guide initial treatment, such as whether to prescribe antibiotics. Platelets are tiny disc-shaped cell fragments, and they become sticky and clump to form a temporary plug, primary hemostasis. The FBC gives an exact platelet count per volume. Low, thrombocytopenia, expect bleeding risk, easy bruising, petechiae, nosebleeds, bleeding gums. Severe cases risk internal bleeding. Common causes include ITP, sepsis and chemotherapy. High, thrombocytosis, often reactive, after bleeding or surgery, with infection or inflammation and in iron deficiency. Persistent, very high counts suggest a myeloproliferative disorder such as essential thrombocythemia. Extremely high counts can make blood stickier, increasing risk of thrombosis, stroke, heart attack, deep vein thrombosis, or pulmonary embolism. Unexplained high platelet counts always warrant further investigation. Beyond counting red cells, the FBC reports red cell indices. The most useful is the mean cell volume, MCV. MCV groups anemia, microcytic, low MCV, normocytic, normal MCV, macrocytic, high MCV. Microcytic anemia is most commonly iron deficiency. Thalassemia, a genetic disorder, is another cause. Normocytic anemia can reflect recent blood loss or anemia of chronic disease. Macrocytic anemia is classically due to vitamin B12 or folate deficiency. Alcohol excess, liver disease, and hypothyroidism can also raise MCV. Combining hemoglobin with MCV narrows causes and guides further tests from the very start. A simple classification diagram helps cement this approach in practice. Accuracy begins before the analyzer. Collection, transport, and handling are where most errors occur. A clotted sample traps platelets and produces a falsely low count. Mix EDTA tubes by gentle inversion immediately after draw to prevent clots. Underfilling alters the EDTA-to-blood ratio, shrinking red cells and distorting hemoglobin and MCV. Hemolysis from forceful draws, vigorous shaking, or temperature extremes undermines analyzer reliability. Correct labeling is paramount. Label at the patient's side immediately after collection. Never before, never away. Delays let cells swell or degrade. Aim to analyze within a few hours. Biomedical scientists look for visible clots and heed analyzer flags suggesting clumping or aged samples. They will reject poor quality samples and request recollection to protect patients from misleading results. Good sampling practice prevents false lows, false highs, and unnecessary investigations. Biomedical scientists oversee analyzers, starting with stringent quality control and calibration. They monitor results, watch for critical values, and investigate every flag. When indicated, they create and examine a blood film to confirm morphology, red cells, platelets, and white cell types. They can confirm blasts in acute leukemia or identify features machines cannot, such as sickle cells. For life-threatening findings, a new leukemia or critically low platelets, they telephone results directly to the clinical team. They are the unseen but vital guardians of the FBC. Summary: anemia by MCV, microcytic iron deficiency, normocytic chronic disease, acute loss, macrocytic B12 folate deficiency, WBC high, infection, inflammation, low, viral, chemo, marrow suppression, platelets high, reactive or marrow disorder, low, ITP, sepsis, chemotherapy, when to request an FBC, suspected infection, fatigue or suspected anemia, monitoring chemotherapy, pre-operative assessment. Educational disclaimer: this video is for education only and not for clinical decision-making.